Good morning, everyone. Good morning, everyone. So, without a further delay, let's start it. What is the normal cycle length? What is the normal cycle length? It is 28 days, right? It is 28 days. And what is polymenorrhea? If the cycle length increases, then it is called polymenorrhea. So, what is the cycle length in the polymenorrhea? Not 1 to 2 days increase will be taken. It is 28 minus 7 days. Okay. Polymenorrhea is cycle length, it decreases. Okay. Cycle length decreases. And cycle length decreases 7 days than the normal. So if the cycle length periods are coming in less than, at a gap of less than 21 days, it is polymenorrhea. So these cycles, how the examiner asks the question, examiner asks is this way, that these cycles will be frequent cycles. Okay. Frequent cycles are polymenorrhea. What is oligomenorrhea? Oligomenorrhea is cycle length is more than 28 days. So 28 plus 7 days, here we have to do, that counts to be 35. So here the examiner will give us the keyword infrequent cycles. Okay. What will be the examiner give the keyword? Examiner will give infrequent cycle. That will be oligomenorrhea. Cycle length will be more than 35 days. What is the normal blood loss? What is the normal blood loss? These basic things are quite often asked. Normal blood loss is 50 ml. Normal blood loss is 50 ml. Okay, around 50 ml. If the blood loss is increased, then it is menorrhagia. The term uses menorrhagia. The blood loss is more than 80 ml or more than 6 days. So what is the definition here? Even if the days are increased, then we say that it is menorrhagia. What is hypomenorrhea? Hypomenorrhea is that the blood loss is decreased. So either it is less than 5 ml. See here, it is very less, or less than 2 days. Okay. What is the term metorrhagia used for? Metorrhagia is used for intermenstrual spotting. Along with the regular menstrual blood flow, there is intermenstrual spotting. Okay, there is intermenstrual spotting. Okay, and what is menometorrhagia? Menometorrhagia is intermenstrual spotting plus increased menstrual blood flow. Okay, intermenstrual spotting plus increased menstrual blood flow. Is it okay? Okay. Now, there is given a palm coin classification for AUB. Okay. Palm coin classification. So, this palm word is for the structural disorders of the structural disorder of the uterus. Okay. It can be polyp. It can be adenomyosis. It can be leiomyoma or malignancy hyperplasia. So the palm word is for structural disorder. What are the structural disorder? It can be polyp, it can be adenomyosis, it can be leiomyoma. Leiomyoma is another name for fibroid. All this we are going to discuss today. It can be malignancy. Hyperplasia is also included here itself. Okay. Now, coin stand for the other disorder. What does coin stand for? C stands for coagulopathy. C stands for coagulopathy. Okay. And O stands for ovulatory disorder. Ovulatory disorder. Ovulatory, related to ovulatory, and ovulatory. You all know perimenopausal and puberty and ovulatory disorders are there. Okay. Endometrial problems. like you can say endometrial hyperplasia, all this sorry, and Swiss cheese appearance, cystic glandular hyperplasia. Okay, iatrogenic, and N stands for not classified. Okay, not classified. So let us study if there is more than 45 years, that is perimenopausal, there is menorrhagia. Very important question are coming on this topic quite again and again. If there is age is more than 45 years and menorrhagia is occurring, or there is frequent cycle, then the first test which you will do is endometrial sampling. If the word menorrhagia is written there, you will always do endometrial sampling. You will never go directly to the hysterectomy. Okay, you should know that what is inside, what is causing menorrhagia. Okay, you should have a diagnosis. Okay, and you will not choose ultrasound for endometrial thickness. You are not going to choose ultrasound for endometrial thickness. Okay, you are not going to choose ultrasound for endometrial thickness. Only the one test which you will do is endometrial sampling. Okay, if any diagnosis is written, that is endometrial hyperplasia, simple or complex, or fibroid, or adenomyosis, then you can choose hysterectomy. But if simple menorrhagia is written, then you are not going to use hysterectomy as the option. Okay. Okay. Now let's start with the another frequently asked question: post-coital bleeding and post-menopausal bleeding. What is the cause of the post-coital bleeding? Post-coital bleeding, most common cause or is CA cervix. Okay, what is the most common cause? Or it is CA cervix. Okay, CA cervix. And what is the first diagnosis? What is the first step you will take if a patient comes to you with post-coital bleeding? Because it is a specific symptom of CA cervix, you will do colposcopy biopsy. Okay, you will do colposcopy biopsy if the cervix has no lesion. If the cervix has no lesion. But if the cervix has any lesion, that is a growth is present, or any type of suspicious lesion is present there on the cervix, then you will undergo punch biopsy. Okay, if any no lesion is present, it means you have to find the lesion, then only you can take biopsy. You cannot cut the entire cervix. So then you will do colposcopy biopsy. But if you are able to see the lesion, then you will do punch biopsy. Okay, if the lesion is present there. Is it okay? Now let us see about the postmenopausal bleeding. What is postmenopausal bleeding? Postmenopausal bleeding, most common cause is CA cervix, followed by endometrial atrophy. Okay, followed by endometrial atrophy. Last time in the exam they haven't given you CA cervix. In the option CA cervix was not there, so you should know the second cause. In the worldwide, the most common cause is endometrial atrophy, but in India, CA cervix incidence is such a large that CA cervix is the most common cause. Okay, first step is pap smear or colposcopy biopsy, even in the case of postmenopausal bleeding. If a patient comes to you, then even in the case of the postmenopausal bleeding, the first step is pap smear or colposcopy biopsy. Why we are writing here pap smear? We haven't written it on post-coital bleeding because the postmenopausal bleeding is not a specific symptom of CA cervix, because the post-menopausal bleeding is not a specific symptom. So either we will do pap smear or either we will do colposcopy biopsy depending on the PV finding. Okay, if preference will always be given to pap smear. Okay, pap smear will be the first choice, right? Pap smear will be the first choice. Okay. Okay, if pap smear is not in the option, then we will go for the colposcopy biopsy. And then the second step, if in the question they have given you that colposcopy biopsy is done, then the second step will be endometrial biopsy. And which endometrial biopsy is the most good biopsy? It is the hysteroscopic endometrial biopsy. Okay. Now let us see the patient who is coming with puberty and ovulatory bleeding or AUB. Okay, pubertal DUB or pubertal and ovulatory bleeding. So most common cause of pubertal and AUB is abnormal uterine bleeding and ovulation. Okay, in a young female you cannot do DNC. Okay, in a young female, you cannot do DNC in the pubertal female. So please don't mark DNC as your treatment. Okay, in a young female, you have also to rule out coagulation disorders. Okay, you have also to rule out coagulation disorder. So what is the main cause of AUB in puberty? The main cause of AUB in puberty is an ovulation, and you have to rule out coagulation disorder, no doubt. Now let us see what is the perimenopausal AUBs and ovulatory. The histopath finding is cystic glandular hyperplasia or the Swiss cheese appearance. Cystic glandular hyperplasia or the Swiss cheese appearance. It is similar to simple hyperplasia without atypia. Okay. So this was about the anovulatory bleeding. Let us see treatment of menorrhagia. The drug of choice is tranexamic acid. How do the tranexamic acid act? It is a antifibrinolytic. How it acts? It is a antifibrinolytic. Okay. So it decreases the bleeding. It is an antifibrinolytic. So it decreases the bleeding. Okay. The second drug is OCPs. And the third, or OCPs or progesterone you can say. But there is no documented role of ethamsilate. There is no documented role of ethamsilate. If a young female is coming to you with acute bleeding, then the treatment of choice is estrogen plus progesterone. Estrogen plus progesterone if the patient is coming to you with acute bleeding. Okay, young female acute bleeding, because we cannot do DNC over there. Okay, hormonal disorders. Let us see what is the first sign of puberty. What is the first sign of puberty? It is growth spurt. And what is the first specific or visible sign? They will confuse you by using this term. The first sign is growth spurt and the first specific or visible sign is thelarche. This is a mnemonic to understand what are the sequence, but questions will be asked only on these two things. What is the first sign or what is the first specific visible sign? BPH in males. Benign prostate hyperplasia in males. Breast, first sign is breast growth, visible sign. Okay. P stands for pubic hairs. H stands for peak height. And M stands for menarche. Okay. So menarche is the one to come in class. What is precocious puberty? If the puberty comes before 8 years. Please remember this term, 8 years. If the puberty comes before 8 years, what is the most common cause? Idiopathic or central? Okay. Idiopathic is same as central. So you will not confuse yourself. 80% it is idiopathic or central. What is the drug of choice on a patient of precautious puberty? It is GnRH agonist, continuous one. Because continuous, giving the GnRH continuous, not in the pulsatile. Giving the GnRH continuous will stop the GnRH release. Now let us talk of most common cause of peripheral precocious puberty. What do you understand by peripheral precocious puberty? Peripheral precocious puberty means that estrogen is not produced due to the hypothalamus or pituitary hyperfunction. Okay. The most common cause is McCune-Albright syndrome. Here, the drug of choice is aromatase is enzyme inhibitor. What drug we give? Aromatase enzyme inhibitor. Is it okay? What drug we give? Aromatase enzyme inhibitor. Now let us study dysmenorrhea. This is very favorite of FMG people. Okay, FMG examiner. There are two types of dysmenorrhea. Primary dysmenorrhea and secondary dysmenorrhea. What is primary dysmenorrhea? The another name of primary dysmenorrhea is spasmodic dysmenorrhea. Then the secondary dysmenorrhea, other name is congestive dysmenorrhea. Okay. So what are the other name for primary dysmenorrhea or spasmodic dysmenorrhea? Is that let us see why it happens. It has been asked in the PYQ. Ovulation occurs. With the ovulation, there is the release of prostaglandin F2 alpha. With the ovulation, there is release of prostaglandin F2 alpha. This F2 alpha, it goes and sits below the endometrium. Okay, it goes and sits below the endometrium as there is progesterone withdrawal. When there is progesterone withdrawal, then this is released. Okay, and it contracts the myometrium and open the cervix. So cervix should be open for periods to come out, for the menstrual blood to come out. So who it is doing? It is being done by prostaglandin F2 alpha, and this is released at the time of ovulation. This is very important. This is released at the time of ovulation. Okay, and this contractions caused by prostaglandin alpha, it causes all the dysmenorrhea. So even without any diseases, any diseases, this primary dysmenorrhea is present in every female. Okay, so it is only for day one. This primary dysmenorrhea is only for the first day. Okay, and what are the drugs of choice? Is NSAIDs. Even if with NSAIDs it is not treated, then you will give OCPs, because OCPs is stop ovulation. Oral contraceptive pills, they stop ovulation. Okay. Next is secondary or congestive dysmenorrhea. If there is some etiology is there, this is very frequently asked question. What is the most common etiology of dysmenorrhea? Can anybody write down in the chat box? Endometriosis. Okay, or PID or adenomyosis. Okay, so the most common etiology is endometriosis, PID or adenomyosis. Here the pain is from day 1 to day 4. All the 4 days there is pain. Okay, in primary dysmenorrhea, as it was just to open the cervix, the pain was only for the first day, whereas in the secondary dysmenorrhea, the pain is for the whole day. Okay, now there is also one more pain that is known as Michel's-Mers, that is occurred during the time of ovulation. So it occurs on day 14. Because it occurs due to ovulation, so here the drug of choice is NSAIDs followed by OCPs. Okay, here the drug of choice is NSAIDs followed by OCPs. Let us discuss premenstrual syndrome. First of all, it is premenstrual syndrome. All the females suffer some premenstrual symptoms. Okay, before the menses, they have some symptoms. If that symptoms are so much large that they cause disturbance in the life, then it is known as premenstrual symptoms. They are found in the people who find in the girls who take more stress, more caffeine, or more estrogen and decreased progesterone. Okay, so the hormonal derangement which is present is increased stress, increased caffeine intake or coffee, or you can say tea intake, and increased estrogen and decreased progesterone is the hormonal disturbance. Okay, increased progesterone and decreased progesterone is the hormonal disturbance. So what is the drug of choice? This is the question asked. What is the drug of choice in premenstrual syndrome? The drug of choice is SSRI. The drug of choice is SSRI. OCPs can be given. Oral contraceptive pills, they can be given, but not Mirena, because what is the hormonal problem? Increase estrogen and decrease progesterone. So both the hormonal problems will be accurated by the OCPs, but Mirena will not act. Mirena will not act. So this is a question which can come to you. It was a PYQ in the other exams, that can Mirena be given in PMS? No. Oh, it will not solve PMS. OCPs can treat the PMS. The other things which can be given are the patient should do exercise, because it releases the amphetamines. Should have a good sleep. Calcium and vitamin B6 are the drug of choice. Okay. Now we are going to discuss the estrogenic conditions. Okay, now in all the conditions which we will be discussing, there is hyperestrogen. Whenever there is hyperestrogen, so there is increased endometrial hyperplasia. Okay, so the main symptom of all these things will be menorrhagia. After progesterone withdrawal, there will be menorrhagia in all of these. Let us now first study with endometriosis. What is endometriosis? Presence of endometrium outside the uterus. This outside word is very important. Okay, this outside word is very important, because if it is present inside the uterus, it will be adenomyosis. Okay, now what is the theory? The theory is given by Sampson. Sampson says that when the periods occur, there is a retrograde menstrual flow. So this endometrium which was being shedded, it goes and implant in the ovary. So most common site of endometrial implantation is, it is going via the fallopian tubes, and most common site is ovary, followed by pouch of Douglas. So this can be asked, second most common site of endometriosis. Second most common site of endometriosis. Now when this endometrial glands, they go in ovary or they go in pouch of Douglas, then they undergo changes in the next cycle as our endometrium goes. What are the changes in the next cycle? They undergo proliferation, secretion and menstruation. Okay, in the next cycle. Now these proliferation, secretion and menses in the ovary and pouch of Douglas will cause adhesions, inflammation and chocolate cyst in the ovary, because the uterus has its own outlet, whereas the endometriosis does not has its own outlet, right? So the endometriosis, it undergoes, so wherever there is endometrial deposits, it will undergo adhesions, inflammations, and in the ovary there will be formation of chocolate cyst. Deposited blood will clot and there will be formation of chocolate cyst. Okay, now what is the investigation of choice? The investigation of choice is laparoscopy. Why? Because now only I told you that there is formation of adhesions. So these adhesions will be seen only on laparoscopy. Okay, ovarian chocolate cyst can be seen, but these adhesions can only be seen on laparoscopy. Usually laparoscopy is always the best diagnosis, but in the endometriosis it is the investigation of choice. Okay, there is ground glass. What is the appearance of this? Is the chocolate cyst. Okay, this is the chocolate cyst. Okay, see, it has ruptured and chocolate color fluid is coming. This is the ultrasound of chocolate cyst. What is here? Here there is ground glass appearance. Okay, so here there is ground glass, or you can say hazy appearance. Why there is ground glass appearance? Because there is clotted blood in it. Because there is clotted blood in it, and that clotted blood gives the appearance of ground glass. Okay, so these are the gunshot or powder burnt appearance. Okay, these are the gunshot or powder burnt appearance which we see on laparoscopy. Okay, what is the PV finding of endometriosis? What is the PV finding of endometriosis? The uterus size is normal. The uterus size is normal. This is very important, because in all other hyperestrogenic conditions, we will see that the uterus size is not normal. In the endometriosis, because the endometrial tissue has gone outside the uterus, beta, so there will be the uterus size is normal. Okay, and there is fixed uterus, or you can say retroverted uterus felt on PV. As if there is ovarian cyst or chocolate cyst, then there will be tubo-ovarian mass felt. If we are talking of pouch of Douglas wala endometriosis, then there will be fixed uterus or retroverted uterus. Okay, what are the symptoms seen by the patient? So menorrhagia will be there. As I told you, it is a hyperestrogenic condition. So menorrhagia will be there. Along with menorrhagia, there is congestive dysmenorrhea. Okay, so as I told you, it is very frequently asked. So the most common and most persistent and most important symptom is dysmenorrhea. So that is why they ask you. Secondary dysmenorrhea is seen in congestive dysmenorrhea. Along with dysmenorrhea, as we studied that there was adhesions. Whenever there will be peritoneal adhesions, it will lead to dyspareunia. Dyspareunia is present in PID also, because in PID also there is adhesions. Okay, and because such adhesions, they distort the anatomy, and there is so much of swelling due to that ectopic endometrium. So the patient suffers from infertility. What is the age of the patients in which endometriosis occur? It is a career making age, 25 years to 35 years. Okay, for this I always tell my students, endometriosis occurs in your age and adenomyosis occurs in my age. Okay, endometriosis occurs in your age and adenomyosis occurs in my age. So what is the treatment of chocolate cyst? This was a last year FMG question. What treatment? They have given you a ground glass appearance and they have asked you what will be treated. Whether you will remove the chocolate cyst or you will give the symptomatic treatment. So here it is say, if the chocolate cyst is producing symptoms or or it is more than 5 centimeter, or it is more than 5 centimeter, then we will do cystectomy. If it is producing symptoms, or it is good morning Dr. Rachna, if it is producing any symptom, infertility, dysmenorrhea, or menorrhagia or dyspareunia, then we will remove the cyst any size, or if it is more than 5 centimeter, then we will remove the cyst. Okay, so cystectomy will be done. In the question of the FMG last year, the size was 8 centimeter, so the answer was cystectomy. Okay, what is the medical management? Medical management is, now if this ectopic endometrium will proliferate, then it will cause adhesions and then it will cause problems. So better is not to let that endometrium to proliferate. So what are the drugs which not let the endometrium to proliferate or decrease the endometrial proliferation? The drugs are OCPs. As you know that in OCPs the estrogen content is quite less, so there is decreased proliferation. And next is progesterone. Okay, progesterone, because progesterone stops the endometrial proliferation. So if you will give from day one, the other drugs which stops the GnRH release and thereby stops FSH and the estrogen release, the other drugs are danazol and anti-GnRH, and they has to be if you are giving GnRH analogs, they have to be continuous, not pulsatile. Pulsatile will act like GnRH. Okay, danazol is also anti-GnRH. You can give GnRH antagonist and you can give GnRH analog continuous. What is the treatment of infertility? If the patient has infertility, this is again a PYQ. What is the treatment of infertility? The treatment, if it is a mild endometriosis case, then we will give clomiphene citrate and IUI 3 cycles, intrauterine insemination. But if it is a case of moderate or severe, then we will do adhesiolysis followed by IVF. Can you tell, we are doing IVF, then why we are doing adhesiolysis? We are doing adhesiolysis because even in IVF, implantation has to occur. Okay, if it is not a good uterus or a faulty implantation, then the IVF will also abort. Okay, so adhesiolysis is must in the case of moderate or severe endometriosis. Now let us study adenomyosis. Endometrium in myometrium. So now endometrium has gone into the myometrium. Now why it has gone? This is a PYQ. Okay, it has gone due to breakage of the endometrial myometrial junction at the time of delivery. When a normal delivery or cesarean delivery occurs, the endometrial myometrial junction, it breaks, and when it breaks, then it the endometrium goes into the myometrium. So when it breaks, the junctional zone appears more than 12 mm. Okay, as you can see in this diagram, that here there are, this is the endometrium in the myometrium. Okay, so this gives the appearance of salt pepper appearance. Okay, salt pepper appearance, right? Then myometrial cyst, these are also myometrial cysts. So these are the characteristic finding of adenomyosis, that the junctional zone is more than 12 mm. Junctional zone is more than 12 mm. Now let us see what is the investigation of choice. In endometriosis, investigation of choice was laparoscopy, and here we have to evaluate the muscle. So investigation of choice is MRI. Please don't say ultrasound. Okay, investigation of choice is MRI. Okay, now the junctional zone, it increases. The junctional zone, it increases. Okay, So examiner can confuse you by saying poorly defined junctional zone. Poorly defined junctional zone. Examiner confuses you by saying in poorly defined junctional zone. It also means the same, that junctional zone has increases. There is presence of myometrial cyst and subendometrial cyst. These appearance, can you appreciate these hazy appearance? This is known as Venetian blind. Venetian blinds. Blinds are curtain. Okay, so these are known as Venetian blinds. That stripes curtain are known as blinds. Venetian blinds. Okay, what are the symptoms? We have studied that in endometriosis, the main symptom is dysmenorrhea. But in adenomyosis, the main symptom is menorrhagia and dysmenorrhea. Okay, because this adenomyosis is occurring in a multiparous lady. Each time the lady delivers, the endometrial myometrial junction breaks. So it is found in multiparous. It is found in multiparous. What is the PV finding? The typical word which is used is symmetrically enlarged uterus, because myometrium has gone inside the uterus. So this uterus has enlarged. Okay, and it is 10 to 12 weeks. Okay, the treatment, because the patient is multiparous, so the treatment is hysterectomy. Okay, now let us discuss fibroid. Fibroid, another name is leiomyoma or myoma. Please learn the other names also. Question can come on other name also. Okay. Now, what is fibroid? It is a benign tumor of myometrium or smooth muscle cell. That is why its name is myoma or leiomyoma. Myoma means muscle tumor. Leiomyoma means smooth muscle tumor. It has very high incidence. Its incidence is 50 to 80%. Okay. On histopath, we see all the cells which have increased, they get arranged in a whorled pattern, that is circular pattern. It is the most common. It has such a high that around 50 to 80% of females, they have fibroid, and it is the most common tumor of the mankind. Such a high incidence is not present in any diseases. Okay, so intramural, what is there are three type of fibroid. Out of all these, this one is intramural. Okay, this one is intramural. They will give you picture where which they will identify. This one is intramural, and this one is submucosal, which is in the endometrial cavity. It is submucosal, which is inside the myometrium. It is intramural, and which is here outside here, outside the toward the serosa, it is subserosal. What are the question asked on intramural? Because I told you that all the tumors, they originate from smooth muscle cell or myometrium. So all the tumors are intramural in origin, and most common is intramural, because all the tumor will start from the myometrium. So it is most common. Submucosal fibroid, they are most common to cause menorrhagia and infertility. Okay, and subserosal fibroid, here it is not written, they are most common to calcify. Okay, and cervical fibroid, the one fibroid which is present on cervix, last time you all did wrong in the quiz. The cervical fibroid, it causes urine retention. Okay, now what is the investigation of choice? The investigation of choice is ultrasound. What is the PV finding? The PV finding is that the uterus is enlarged, but it is asymmetrical enlarged. Please mind it, it is asymmetrical enlarged. It is asymmetrical enlarged. Okay, wherever there is fibroid, only at that site it will be enlarged. Okay, now what are the symptoms? The only mainly, most commonly, it is asymptomatic. That is why all the females, in spite of such a high incidence, they are living a normal life. Okay, so most common symptom is asymptomatic. If any symptom will be present, then it will be menorrhagia. Okay, treatment of asymptomatic fibroid, you will not do any treatment. It is clearly written in Williams. Okay, if the fibroid is submucosal, it is asymptomatic, and if it is submucosal or an infertility is present, then you will do myomectomy. All these exceptions have been asked in NEET PG. Okay, if that fibroid is submucosal and there is menorrhagia, then you will do myomectomy if the age is less than 40 years. If the age is more than 40 years, then you will do hysterectomy. Okay, then you will do hysterectomy. Clear? So you are not going to touch asymptomatic fibroids. You are not going to touch, or the fibroid which is present, which after becoming subserous. Dr. Rahul has asked what is broad ligament fibroid. The fibroid which have from the subserous has gone into the fibroid, broad ligament. Okay, so submucosal fibroid are the fibroid which if there is menorrhagia. So if there should be any symptom should be there for to do myomectomy, and if the age is more than 40 years, then you will of course do the hysterectomy. Okay, now let us discuss degeneration of fibroid. Most common degeneration is hyaline degeneration. Okay, most common degeneration is hyaline in degeneration. Okay, and in pregnancy, because there is fetus in the pregnancy, this fetus obstructs the vein. Okay, this fetus obstructs the vein and it causes venous thrombosis. So there is red degeneration. Okay, so there is red degeneration. So the patient in the pregnancy, we cannot do myomectomy, because in the uterus, what is implanted in the uterus, fetus is there, right? So we cannot touch the uterus, we cannot do myomectomy. Okay, we cannot do hysterectomy, of course, we cannot do myomectomy. So we have to do conservative treatment. So we have to give the painkillers and IV fluids only. Due to that, obstruction of the vein in the fibroid, color gets red, so it is known as red degeneration. Even if there is a question PYQ, 16 weeks fibroid in the pregnancy, whether you will treat or not treat, you will not treat, whatever is the size. Okay, let us discuss the differential features between fibroids, endometriosis and adenomyosis, so that it will help you. As I told you that all these are hyperestrogenic stage, so they will all present with menorrhagia. Okay, fibroid can be found in nulli or multi because they have such a high incidence. Endometriosis is always found in nulliparous. Adenomyosis is always found in multiparous. Okay, but the most common symptom of fibroid is menorrhagia. Usually it is asymptomatic. If any symptom is present, it will be menorrhagia. In the endometriosis, the most common symptom is dysmenorrhea, most important, followed by dyspareunia and menorrhagia and infertility due to adhesions. In the adenomyosis, the menorrhagia and dysmenorrhea will be there. Wherever there is ectopic endometrium, dysmenorrhea will occur. But the PV findings here, they confuse you a lot. The PV findings in the fibroid is enlarged uterus and nodular finding, not symmetrical. Wherever there is fibroid, only that part will enlarge. The finding of PV in the endometriosis is fixed uterus and retroverted uterus, but it will not be enlarged. All the adhesions finding. Okay, In the adenomyosis, the findings are enlarged, symmetrically enlarged uterus. The investigation of choice in fibroid is ultrasound. Of course, the MRI is the best investigation. In endometriosis, first diagnosis you have to go for investigation, you have to go is laparoscopy, and in adenomyosis it is MRI. In the treatment of nulliparous in the fibroid is myomectomy if it is symptomatic. In the multiparous it is hysterectomy. In the treatment of endometriosis is cystectomy, adhesiolysis, anti-GnRH in a non-pregnant. If the patient wants to conceive, in the young patient, if the patient wants to conceive or has infertility, then we have to see it is mild or moderate. In the adenomyosis, of course, the treatment is hysterectomy. Okay. So, I think you all are waiting for the quiz. If there is any query, then do tell, or I will post the quiz then. Do you want to continue the class and take the quiz in the next session, or you want to attend the quiz? No, uterine artery ligation is a treatment of fibroid. It is not a treatment of adenomyosis, beta. In adenomyosis, the main pathology is in adenomyosis, the main pathology is endometrial glands in the myometrium. So, uterine artery ligation will not solve the problem. In fibroid, by decreasing the vascular supply, we can solve the problem. Any other problem? Please write down in the chat box. Do you want to continue the class with PCOS, or you want to attend the class after the quiz? Focal adenomyosis is found in young female, and yes, focal wedge resection can be done. Okay, continue the class. So you can take that, take the quiz in the next session. Okay, let us start with PCOS. What is PCOS? In the PCOS, there is multiple small ovarian follicles that not rupture. What is in the present in PCOS? In PCOS, Dr. Rahul is saying after the quiz. Dr. Rahul, you can take the quiz after it. I have started now. I will, after the class, I will restart the quiz. Okay? I will restart the quiz after the class. Okay? So, in the PCOS, there is multiple small ovarian follicles, or usually, as you all know, that one follicle matures around 14th day, but in PCOS, multiple ovarian follicles they start, and none of them rupture, none of them ovulate. Okay, none of them ovulate. So this is the basic pathology. Because it is not rupturing, so there is no progesterone. As you know, ruptured ovarian follicle will form the corpus luteum, and corpus luteum will form the progesterone. Because there is no progesterone, so LH keeps on increasing. This hormonal profile is very important. Please focus here. The LH keeps on increasing because there is no progesterone. Okay. Now here I would like to tell you, please remember the another name of PCOS, anovulation, and it is also known as Steen-Levendel syndrome, because Steen and Levendel had described them. The another name is Steen-Levendel syndrome because Steen and Levendel have described them. Why there is increased LH? If you want to learn only one thing in PCOS, then please learn that there is increased LH. Why there is increased LH? Because there is no ovulation. so no progesterone, so there is increased LH. Okay, because there is no progesterone, so there is oligomenorrhea. So the endometriums keep on proliferating. Endometrium is not going in the luteal phase. Okay, endometrial keep on proliferating. So this is also an increased estrogenic condition. But here there is no, menorrhagia. Rather, there is oligomenorrhea. Okay, in the all the last estrogenic condition there was menorrhagia, but in PCOS there is no menorrhagia, there is oligomenorrhea. You all know this. Because of this increased LH, another pathology happens. What happens? There is theca cell hypertrophy. Okay, there is theca cell hypertrophy. What does is the function of theca cell? Theca cell make androgens from cholesterol. Okay, what does the theca cell do? Theca cells, they make androgen from cholesterol. Now when increased LH will be there will be, when increased LH is there, so there will be increased androgen production. Okay, because there is increased LH, as we studied, was increased LH, so there is increased androgen production from the ovaries. Okay, now what is the size of the ovary on ultrasound? Let us see. Now we should know how we can diagnose this. We can diagnose it by Rotterdams criteria. What is Rotterdams criteria? Rotterdam has given us 3 features. Out of these three, 2 should be present. Okay, what are those 3 features? Number 1 is menstrual dysfunction or an ovulation. Okay, menstrual dysfunction or an ovulation. They both are one and the same thing. Sometime in the exam, the examiner give us oligomenorrhea. Sometime in the exam, the examiner give us an ovulation. Last time in the quiz, 3 people have told me कि ma'am, you have not written menstrual dysfunction and you are diagnosing PCOS. Okay, so PCOS can be diagnosed even when there is an ovulation. So because you know that oligomenorrhea will occur only if there is an ovulation, then only the proliferation phase will prolong. Okay, the another criteria which the Rotterdam has given us is hyperandrogenism. As I told you, increased LH will cause anovulation and oligomenorrhea, and increased LH will cause hyperandrogenism or hirsutism. Okay, so hirsutism or hyperandrogenism means increased testosterone in the blood, or hirsutism. Third criteria is ultrasound appearance of the PCOS. What is the ultrasound appearance of PCOS? It is very important. For here you have to remember the figure 10. Okay, the ovarian volume increases more than 10. What is the ovarian volume? Ovarian volume increases more than 10 and ovary size decreases, because these follicles, they are of decreased size. In the starting only I told you multiple small ovarian follicle. How much small? They should be less than 10. They should be less than 10. Okay, then only it is a PCOS follicle. So PCOS is not multifollicle diseases. PCOS is PCOS is not polycystic diseases. There are no cysts. There are polyfollicles. Okay, there are polyfollicles. So Rotterdam says that out of these 3, the 2 should be present. The 2 should be present. Then okay, Rotterdam says that out of these 3, 2 should be present. So examiner always confuse you by saying that Doing that, ultrasound appearance is normal. Ultrasound appearance is normal. Even if ultrasound appearance is normal, you are going to label it as PCOS if a menstrual dysfunction and hirsutism is present. This is the ultrasound of PCOS. Okay, this is the ultrasound of PCOS, and this is the ultrasound of OHSS, ovarian hyperstimulation. So you can see that here there are follicles which are arranged in the periphery. Okay, here the follicles are arranged in the periphery. This is known as necklace or ring of pearl appearance. Whereas in the OHSS, the follicles are of very large size and the ovary has only follicles. Okay, now let us discuss OHSS. We will discuss this in 1 minute. Okay, whenever we do IVF, we stimulate the ovary. But if ovary gets hyperstimulated, if there is any sensitive patient or the patient has PCOS already, whatever is the factor, if the ovary get hyperstimulated iatrogenically, then this ovary, in the body there is formed VEGF. The question can come on VEGF because it is center of the pathology of OHSS. So then it is known as ovarian hyperstimulation syndrome. And then there is formation of VEGF, vascular endothelial growth factor. What does this do? This breaks the endothelium. What does this do? It breaks the endothelium of the vessels. So what happens? All the intravascular fluid goes into the extravascular space. All the fluid from the blood vessels go into the extravascular place. Can you tell me what are the extravascular space? The extravascular space are, yes, can you tell me what are the extravascular space? Is effusion, ascites, all these are extravascular space. Okay, so fluid goes from intravascular to extravascular space. So what is the treatment? The treatment is to give the IV fluids, and to tap the effusion and ascitic fluid. Okay, to increase the intravascular fluid, we will give IV fluid, and all the fluid which has gone into the extravascular space, we will tap it out. Okay, so that is why it is tell that pani pilate raho, nikalte raho, because the main pathology is all the fluid has gone from intravascular into the extravascular space. So what is the treatment of OHSS? The treatment of ovarian hyperstimulation syndrome is pani pilate raho, nikalte raho. So this is the feature. So you have to differentiate between PCOS and ovarian hyperstimulation syndrome. So what are the hormonal profile of PCOS? You are going to see here. The LH increases, as I already told you. The androgen increases. Now this androgen gets changed into estrone in the peripheral tissue. Estrone means number 1 estrogen. So E1 also increases. Okay, normally the FSH to LH ratio is 2:1, but because here LH has increases, so FSH to LH ratio becomes 1:2. Okay, because estrone is increasing. So normally the ovary estrogen is E2. Estradiol. In the last it is diol is written 2. Ovary estrogen is estradiol. So this androgen is converted into estrogen in the peripheral tissue. So E1 increases. So normally the ovary estrogen is more, but here in the PCOS the E1 increases. So E2 to E1 ratio is also reversed. Okay, what is the normal value of the androgen? Up to 70. The normal value of the androgen is up to 70. In PCOD it doubles up. Okay, in PCOD it doubles up. it goes up to 150. Okay, and what is the level of progesterone? There is no progesterone in PCOD because all the androgens have increased, so sex hormone binding globulin decreases. Because the androgens have increased in the blood, so these androgens bind to sex hormone binding globulin, and the sex hormone binding globulin decreases. Okay, so now you tell me, what is the drug of choice for oligohydramnios? If a young female is coming to you with PCOD, the drug of choice for oligomenorrhea and hirsutism, what is the drug of choice? OCPs. Okay, because OCPs corrects the hormonal profile, and they also correct the hirsutism. Which OCPs you will give? You will give fourth generation or third generation. Why? Because in the third generation, the hirsutism is very minimal, and whereas the fourth generation, they are spironolactone derivative. So can you tell me what is the third generation OCP pill? The one which contain the progesterone desogestrel. And what is the fourth generation? One which contain drospirenone. Okay, as according to the progesterone, there are different types of there are 4 types of OCPs depending on the progesterone. 4 generation of OCPs. The first 3 generation, they are testosterone derivatives, and the 4th generation is the spironolactone derivative progesterone. The first 3 generation, from the testosterone the progesterone is made, and from the 4th generation, in the 4th generation it is spironolactone is making the progesterone. Okay, so these all first, second and third generation, they are divided into first, second and third depending on the how much androgenic side effect is there. In the first generation, there is maximum androgenic side effects. Okay, in the second generation, there is less, and in the third generation, there is least. So if a patient is coming to you with PCOS, then beta both the treatment of Dr. Kavita is asking the treatment of PCOS or PCOD. Beta both the treatment is same, number 1, and number 2, I would like to say you now there is no differentiation. When we used to study, there was differentiation between PCOS or PCOD 10 years back. Now they are taking the both. Okay, both as one and same thing. Now let us study. Now the third generation progesterone is desogestrel, and the fourth generation progesterone is drospirenone. Is it okay? Okay. Now we were discussing the treatment. Now because the patient will also have an ovulation. So for the an ovulation, the drug of choice in PCOS, this is going to come in your exam, mind it, letrozole. Okay. Now why initially when we used to study, clomiphene was the drug of choice. Now clomiphene has replaced the letrozole. Why is it so? It has replaced the letrozole. It is so because the clomiphene is these questions have come on each of this line. Why letrozole has replaced clomiphene? Questions has come many times. Okay. So the letrozole is a basically aromatase inhibitor. Okay. And the clomiphene is a SERM, selective estrogen receptor modulator. So it is estrogenic at some site and it is anti-estrogenic at the other site. Okay, it increases the GnRH. Okay, as it is SAM, so it increases the GnRH by blocking the estrogen receptors in the hypothalamus. Okay, by blocking the estrogen receptor in the hypothalamus. So it increases the GnRH, so it increases the follicle size. Increase the GnRH, increase the FSH, and increase the follicle size. Okay, this is aromatase inhibitor. What does aromatase do? Androgen are converted into the estrogen. So by increasing the estrogen, the follicle size is increased. Okay, because this is the SERM, selective estrogen receptor modulator, so it is anti-estrogenic on endometrium. So it thins the endometrium. Okay, because it thins the endometrium, so implantation is a problem then. Okay, implantation becomes a problem. Okay, so the live birth rate, it decreases. Right, the ovulation occurs. Due to increase in FSH, the ovulation occurs, but it is anti-estrogenic on endometrium, so the implantation becomes very difficult on the thin endometrium and live birth rate decreases. That is why, because we are not getting pregnancy, because we are not getting fetus, the live births, that is why the letrozole has replaced it. Okay, there are some more advantages of clomiphene. In spite of all these advantages, we have replaced the clomiphene. Okay, what are they? It causes multifollicular development. It causes multifollicular development. What is multifollicular development? Multifollicular development means many follicles were made. That is good for the infertility patient. But since many follicles were made, still we have to replace because we were not getting the live birth rates. Okay, so this was the one advantage of clomiphene, that they were multifollicular development. Okay, then they were not teratogenic. This clomiphene was not teratogenic. Last year a question has come, what is the half-life of letrozole? Okay, what is the half-life of letrozole? There, why it was asked? Because letrozole itself is a teratogenic drug, but its half-life is very small, 48 hours. So before that fetus is formed, the fetus is formed at 14th day, right? And we are giving this ovulation induction drug in the first 5 days. So by the time the fetus will be formed, this letrozole has gone out from the body. Okay, so that is why the letrozole has half-life was asked, because basically the letrozole drug is a teratogenic. Okay, because basically it is a teratogenic drug. Okay, so its half-life is only 48 hours. Okay, so that is why it has replaced. Okay, the only single reason why it has been replaced, the single reason is that at the live birth rate was more. The live birth rate was much high. Okay, letrozole causes monofollicular development. Letrozole is teratogenic, but in spite of teratogenic, it was taken because its half-life was very small. Okay, and clomiphene was replaced because it causes very less live birth rate. Okay, now what are the other two syndromes associated with PCOS? As you know, all the related things are much asked in our exams rather than asking the main thing, which have been asked. Time to give, Dr. Isra has asked time to give letrozole and I think I missed that. Yeah, it was written here. Time to give, it was in the first 5 days. Day 1 to day 5. Letrozole is such an important. I would ask you to please learn the dose of letrozole. It is 2.5 mg to 7.5 mg depending on what dose the patient wants for 5 days. Day 1 to day 5. Okay? Okay. Now, there are two syndromes associated with PCOS, or you can say insulin resistance. One is hair N. What is hair N? Hyperandrogenism. Hyperandrogenism. Okay, HA stands for hyperandrogenism. Hyperandrogenism means formation of more androgens. Okay, hirsutism will be there. Then there is IR. IR stands for insulin resistance. This is typically found in obese females. Okay, obese females. There is hyperandrogenism, insulin resistance, and AN stands for acanthosis nigricans. The velvety texture of the neck, the subcubital fossa, or near the thighs, inguinal, there is a velvety texture, dark texture, acanthosis nigricans. Okay, because hair N is also due to the insulin resistance, and PCOS is also due to the insulin resistance. So this is associated. And next is metabolic syndrome. You all know what is hair N and metabolic syndrome. So you can see all the important images related to these topics have been given in the Telegram channel. Please, you can see from there if I have missed copying them here. All the images have been given. What are the long-term complications? The long-term complications are all estrogenic diseases. What are the estrogenic diseases? Ovarian cancer, endometrial cancer, and then what are other breast cancer. All the estrogenic conditions are the long-term problems. Okay, then diabetes mellitus and hypertension can also occur because you are right, Dr. Isra, because the main pathology is insulin resistance, so diabetes and hypertension also occurs. But you have to remember that osteoporosis is not a symptom, because osteoporosis is a decreased estrogen symptom. Osteoporosis will never occur here. Let us discuss the second last topic, hirsutism. Hirsutism is the growth of the hair in male pattern. Male pattern. Growth of the hairs in a female in a male pattern. So basically, what is the source of hairs in the male? It is androgens. And from where these androgens are made? Can you tell me? Usually it is the peripheral tissue which is the source of the androgen. Okay. Usually it is the peripheral tissue which is the source of androgens and which is responsible for the hair growth. So if there will be increased androgens, so there will be hirsutism. In which problem? Yeah, I'm coming to that. In which problem the ovary is the source of androgen? Now only we studied in which problem ovary is the source of androgens in a female. It is PCOS. And in the PCOS, the testosterone levels are less than 150. The source is adrenal cortex. In which problem? Adrenal cortex becomes the source. In which problem? Very good, Dr. Isra. In the adrenal tumors. So if testosterone is going more than 150 and there is rapid onset hirsutism, then it is a case of adrenal tumors. So if the testosterone is more than 150, do suspect adrenal tumors. Okay? Okay, can you tell me a problem in which there is testosterone is increased and there is also virilization? Juvenile onset adrenal hyperplasia. Okay, there 17-hydroxyprogesterone is also increased. Okay, now let us study hyperprolactinemia. You should know only 2 points about hyperprolactinemia. Please focus here. The topic will be finished. That increased prolactin decreases GnRH. That is why it leads to amenorrhea. It will be asked in the question that increased prolactin inhibits hypothalamus or pituitary. It inhibits hypothalamus. Okay, it inhibits hypothalamus. Okay, and in a lactating female, when is the prolactin maximum? When is the prolactin maximum? In a lactating female, the prolactin is maximum just after the lactation. It is a basic question and it has been asked with very confusing option: after lactation, before lactation, after delivery, before delivery. So the answer is just after lactation. When a female lactates, then there is formation of oxytocin and prolactin both, not before lactation. When a female lactates, once the newborn is sucking, then there is release of oxytocin and prolactin. Prolactin does the further lactogenesis and oxytocin cause the milk letdown. Okay, now tell me what is the drug of choice for hyperprolactinemia? This question is being asked to me by many of the students. I want to remove every confusion. If the lady is conceiving or the lady is pregnant and there is a prolactinoma tumor in the brain, then you will give bromocriptine. You will give bromocriptine if the lady is pregnant or the lady is trying to conceive. Okay, because the otherwise you will give cabergoline. Why you don't give cabergoline in pregnancy? Because it interferes with ovulation. It interferes with ova growth. So abortion can occur. So that is why if the lady is not planning of pregnancy, then we will always give, or if the lady is not. No, it is, Dr. Isra is asking, it is maximum in pregnancy or after lactation. It is maximum after lactation. Okay. So what is these drugs? How do they act? The bromocriptine and cabergoline, how do they act? Can you write down the mechanism of action? Can you write down the mechanism of action? What is the relation between prolactin and dopamine? Yes, these both drugs, bromocriptine and cabergoline, they are anti-dopamine. anti-menergic. They are anti-dopaminergic. Okay, they are anti-dopamine. Okay, so they decrease the prolactin, right? So that is why they are given. They both are anti. So whenever a lady is conceiving or the lady is pregnant and the lady has, what are the symptoms of hyperprolactinemia? Can you tell me two symptoms of hyperprolactinemia? Galactoria and visual symptoms, because the prolactinoma affects the optic chiasma in the brain. That is why there are visual symptoms. Okay, now tell me that if there is a prolactinoma, will you do the surgery or you will give bromocriptine or cabergoline? Write down in the chat box. If there is prolactinoma, will you give bromocriptine, cabergoline or do surgery? Very good. Very good. Very good. Tell me. Yes, if it is a small tumor, then the tumor will decrease in size. So this drug bromocriptine and cabergoline, they decrease the tumor size. Is it okay? Can we close the session or any queries are left? That's all for today. Can we close the session? Beta, it is not necklace, Dr. Rakesh. In the ultrasound, it is included the ovarian volume. Okay, number one is ovarian volume and number two is size of the ovarian follicle. Volume is more than 10 and the size of the follicle is less than 10. Rotterdam is presence of 3 out of 2. Presence of 2 out of 3. Okay, presence of 2. Anovulation, or you can say oligomenorrhea and hyperandrogenism and ultrasound appearance. And they always confuse you by saying ultrasound appearance is normal. Is it okay? See you all in the quiz. Okay, see you all in the quiz. After 2 minutes, there will be quiz. Question practice is very must for the exam. Please don't miss the quiz.